So good evening to all my dear students. How are you all? So how was ophthalmology? Okay, can you all hear me? I don't see any reply or chats. Just give me a sec because I can't see the chat. Just one. Okay, yeah. Now I can see you all. Yeah. So how was the ophthalmology? Sorry for this. Okay. So I'll start again. So very good evening to all of you. So how was ophthalmology? So saying hello to you all from Canada today. So let's discuss the questions here. I think this time, if I before I begin with the discussion, I think uh, ophthalmology. If you had all attended my lectures seriously, it was 100% strike rate. Each and every question that was asked has been discussed in your class in the lectures. So if you have attended and seen those videos nicely and you have attended properly, studied properly with me, I think ophthalmology should have been a cakewalk for you all. Yes or no? Okay, so I'll try to be a little louder here. Let's start with the first question. What is anisometropia? I think we have discussed this in the class. What is anisometropia? It is difference of refractive power between the two eyes of more than 2.5 diopters. Okay? So when you say difference of more than 2.5 diopters, what will be the answer? Common sense. We are talking about refractive error. Correct? So what are the options? I think many of you must have got confused with difference in visual acuity. We are not talking about acuity. We are not talking about 6 by 6, 6 by 9. Correct? What we are talking is, what is the refractive difference, refractive error? So answer should have been D here. Is it okay? All of you have answered this only? Let me know, please. Yes, so answer is B, and it was a simple question. I think it is also an overlap. I think you have thought about this also. The difference in axial length will also cause ultimately difference of refractive error. Size of the eyeball ultimately is all difference of axial length. So if these options are correct, it was little bit near around it. You know? Okay, anyway, so this was simple. So we can move to the next question here. I'm not in a mood to go for a detailed discussion here because you all are not in a mood. After the exams, you just want to know the correct answers. But I would just put some points more because our NEET PG is around the corner. So if I have to add few points, I would like to add that, please. We come to the next question. I think this was the next question. Yeah. So a patient presents with vision problem in his right eye. So it could be any decrease of visual acuity in his right eye. And on examination, the pressures are so high, right? 50, and left eye is only 16. That means normal, right? We all know the normal intraocular pressure is 10 to 21. Okay, so the slit lamp examination shows presence of flare in the anterior chamber and cataractous lens in the right. So all of you, there is flare, that means there is, and also the lens, cataractous lens is mentioned here. Now let's think one by one. Patient with high pressures has cataract and has all the features of inflammation and also flare. Are we not going to correlate it and think this way that it will be all cataract induced? So if we look at the options, then we can see one by one. First is phacolytic glaucoma. What is the answer? Is it phacolytic, Harish? Azam, why do we say phacomorphic? What is phacomorphic? See, what was phacolytic and phacomorphic? We have discussed in the class as well. When you say phacomorphic, Azam, it means that there is a lens swelling and it is blocking the pupil, right? And therefore the pressures are rising. It happens in intumescent cataract, correct? Right? Okay, so according to you, so it was mainly a pupillary block glaucoma, correct? Okay, in this case, when we are talking about right eye pressure so high, with the left eye is only this, okay, slit lamp examination shows presence of flare in the anterior chamber. And actually, you have to understand that when we are talking about flare in the anterior chamber, it has to be more towards phacolytic, because what is phacolytic? It is again release of the pigments from the, so that is only causing that flare and haziness in the aqueous humor. So what was phacolytic? Phacolytic was leakage of lens protein which was blocking the trabecular meshwork, isn't it? So the leakage of lens protein was due to Morgagnian cataract. We know this. So if you look at the whole presentation, it will go more towards phacolytic. Okay, it should be phacolytic. And let me tell you, Azam and others who are answering D, yes, it can be a little confusing. Why not D? But again, D will not show flare in the anterior chamber. Okay, so whenever we are mentioning a flare, we are talking about what? When we mention a flare, we are talking about inflammation which is induced. So mainly the release of lens protein, it goes more towards that pathogenesis than towards the phacomorphic, right? And of course, that is causing rise of the pressures and that is leading to glaucoma. Again, why not fused heterochromic cyclitis? You all remember fused heterochromic difference of iris color. It's an it's an atypical anterior uveitis. But again, the pressures cannot be so high in this condition, isn't it? It does lead to cataract, yes. But again, the presentation goes more towards phacolytic glaucoma. Okay? And everybody remembers what is malignant glaucoma. We will quickly revise this also. So malignant glaucoma, very shallow anterior chamber, it's also called ciliary block glaucoma, which happens after any intraocular procedure. When the aqueous is sequestered in the vitreous cavity, it is pushing the iris and lens diaphragm forward. And because of the pushing of the iris and lens diaphragm forward, what is happening? That, tell me, it is going to lead to very shallow anterior chamber and a very high rise of pressure. And I hope you all remember, इसको हम लोग क्या पढ़ा था? This is also called inverse glaucoma. Why do you call it inverse? Because we treat it with atropine. What is atropine doing? Atropine is dilating the ciliary ring and helping to open the block, that is ciliary block glaucoma. Correct? We also call it ciliary block glaucoma. I think this is okay with you all, right? So that is the reason if you look at all these findings, we will go more towards phacolytic glaucoma. Okay? Okay. Flare was not given. Okay. Okay, if it was a deep anterior chamber, then phacomorphic is automatically excluded anyway. It goes in more in favor of phacolytic if deep anterior chamber was mentioned. Right? Okay. So when you say Pihu, when you're saying cataract induced uveitis leading to glaucoma, what is it? It is going towards which term in all these four terms? Isn't it? Phacolytic, right? Okay, Sumit, what you're saying, how is that the pressures are high in the other eye? Now, this doesn't make much sense that a patient has a problem and decreased vision in one eye with such a high pressures in the other eye and there's no problem in the other eye. So, are you really sure? Okay, let's, what you will do, we will research on it more. Okay, what was the exact question? Isn't it? How can this be? Try to understand. All these findings have to be correlated, na? That is why. Are you all sure? Other people? What Sumit is saying? Do you all agree with him? What was in your question paper? Deep anterior chamber goes most towards phacolytic glaucoma. You? Okay? Because in phacomorphic, it is the intumescent cataract which is going to block the pupil, the lens iris diaphragm. So when you block the pupil, oh no, I'm so sorry. When there's a pupillary block glaucoma and the aqueous is, yeah. Okay, that is going to be more in favor of phacolytic. More in favor of phacolytic. Because it is going to then lead to pushing of the little bit of the iris and that is going to cause, yes, that's correct. So that is going to lead to what? Your shallow antenna. So that is why this goes more, when deep anterior chamber is given, it's more in favor of phacolytic. ये तो ठीक है. Okay, so you all are saying that the eye with the contralateral high eye had more pressure. This was given. Okay, I'll come back to this. Let me think about it. Why will the contralateral eye have more pressures and how does it then justify this? Heterochromic cyclitis is, why do you answer according to this? It's a unilateral condition. Na? It's an atypical anti-uveitis. It's a unilateral condition, right? So all the symptoms would be there only. Na? Hypochromic iris, with it. Of course, it will lead to the cataract. It may lead to high pressures due to uveitis. So this makes more sense. So we'll just come back to you according to this. If all of you are saying something like this, we'll come back to you. Right? Okay. So that was one thing. Let's take the next question. Yeah. I'm going to come back to this again. I'll discuss this maybe on my channel or maybe otherwise I'll discuss this again. Okay. We'll research it on this. Let's not waste time here. So we'll research. If you all are saying this, that the other eye pressures were high, we will have to really think whether how does it make sense. Correct? Right eye IOP was okay. 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 So I took it. Many of you are saying this. So we will come back to this very soon. Right? But as of now, we have to answer phacolytic glaucoma. We come to the next question here. Which of the following statement is incorrect? I think again we have talked so much about retinitis pigmentosa in the lectures. We all know it is mainly a dystrophy of rods and cones. Rods, of course, are more common than cones. So the statement is correct. ERG, of course, we know we have to have a decreased amplitude of both A and B waves. You all remember this? A and B wave. A is for photoreceptor and B for bipolar. So the impulse has to go from the photoreceptor to the bipolar, correct? So when there is a dystrophy, it is mainly reduction of both the waves, A and B both. I've taught you. It's a flat ERG. In a severe case of RP, you get a flat ERG, correct? Okay. So this is correct. This is correct. Lead presentation is loss of it. So you all know in a typical RP, what did we learn? Do you remember this diagram? I'm making this small diagram here. Do you remember this? What I taught you, that initially what happens is it is only the mid periphery which is involved, and later it is going to extend centrally and peripherally. And at the very late stage, do you all remember what happens? At the very late stage, what you get is a tunnel vision. Everything is gone and only a very small field around the central vision is left behind. And that is what is called tunnel vision, isn't it? So this is, of course, a correct statement. So what is wrong? Night blindness is the earliest feature, isn't it? The moment the patient is going to present. So it's not a late feature, it's an early feature. So I think you all agree with this, right? Yes, so D is the answer. All of you keep answering and talking to me, please. So yes, D will be the answer here. And RP is a very important topic for your NEET PG as well. Be very, very thorough with it. Listen to the lecture again, revise all the points again. Okay. Yeah. So then we come to the next. Of course, this is a typical triad. You must be remembering bony spicules, attenuated arteries, and pale waxy disc. We come to the next question. There is a patient who has a rheumatic heart disease, non-compliant with the treatment, presents with complaints of superior field vision, field loss hoga, vision yoga, field loss. So superior field loss for past 1 week. So there is a photoma here, right? So what is the probable cause of the given condition? So when you talk about the rheumatic heart disease, right? So rheumatic heart disease, if we look at the ocular features, most of commonly it is your anterior segment involvement and other things which are associated with rheumatoid arthritis. Well, so but later when there's a heart disease in the complication, we all know any vasculitis can lead to blockage of vein also and artery, correct? So what should we answer? Common sense, if there is any field defect in any one quadrant, it has to be a branch involvement and not the central vein or retina involvement. So first of all, this is gone. When you talk about branch, of course, it has to be, because it is a chronic thing, it is causing a severe field visual loss, it has to be branch retinal vein occlusion. We have discussed in the class that commonly the branch retinal vein occlusion is superior temporal quadrant, but of course, in this case, if superior field has been gone, it has to be an inferior quadrant, which is in. Keep this in mind. Okay? And of course, we have learned about CRVO, what is flash source appearance, and what is day glaucoma. Please revise all this for your NEET PG as well. Right? Multiple flame shaped hemorrhage, this is CRVO, and 100-day glaucoma. No, Harish, we are going to talk about, we will answer vein. It is branch retinal vein occlusion. This should be the answer. The artery occlusion is all a very acute thing. Okay. So if it is causing any field effect, it has to be a little chronic thing. That is why you should answer branch retinal vein occlusion. Got it? Okay. I think this is clear. Harish, so no problem here. We can go to the next question. Let's take the next one. So this all has been discussed. And of course, please revise your, for your further exams, revise your central retinal artery occlusion is very, very important topic. You all know this, correct? Cherry red spot, edema in the retina, right? We have to know it is causing sudden, painless diminution, loss of vision. It is mainly due to atherosclerosis, embolism. It could be due to mucormycosis, all these points. And what is the critical time of treating a CRAO? It is with 90 minutes. All these, just revise all. These are very important topics given here, right? All these options are important to be thorough with. Okay, so CRVO, CRAO, these are things to be learnt nice for your further. And yes, because we are getting a field effect, it's a chronic damage, we'll answer BR. Okay, okay. Thank you, thank you. Now it's very encouraging when the hearts are flowing. So we come to the next question. The next question is, a 3 months old child presents with photophobia and watering. Which of the following cannot be the cause? It has made the question so simple. आप बताओ, in a small child with the photophobia and watering, what are the mainly the three DDs that come in our mind? It is either congenital glaucoma or congenital retinitis, or it could be ophthalmia neonatorum. These are the three main causes. Please remember that, right? We will remember these three DD as either it is ophthalmos or congenital glaucoma. What is the next? Either it is congenital glaucoma, I said, or it is congenital dacryocystitis, we all know, right? Or it could be, what is the next one I said? Is ophthalmia neonatorum, that is neonatal conjunctivitis. So in a small child, these three DDs should be always on your tips. And let me tell you, all three are important. Okay? But what is not the cause? Think why? Okay, let's take one by one. NLD obstruction, I've already mentioned. Entropion is going to, the lashes are going to rub on the cornea, and therefore the patient will again have the symptoms of photophobia. What is not there is dystichiasis. Did we learn dystichiasis? Yes. What was discussed? What is dystichiasis? It is double row of eyelashes, right? So this is the double row. Naturally, this has to be immediately should be removed, or it can lead to can later lead to a problem. But what we see is, with the photophobia and watering, our answer should be so. What is dystichiasis? Actually, if I while teaching you and I'm thinking, any congenital dystichiasis can rub on the cornea and lead to watering and photophobia, right? It can still, any congenital dystichiasis can also rub at the cornea because these lashes are rubbing. So if these four are the options, uh, gets more confusing. But anything, the best way to answer here, because any entropion is also going to finally lead to rubbing due to trichiasis, correct? So that is the reason. Yeah, photophobia, whenever there is any problem in rubbing on the cornea, it is going to involve the sensory supply, that is the fifth nerve, and it is due to this fifth nerve that you are getting a photo. So any rubbing of the cornea due to any of the reasons can lead to photophobia. Okay, so in this case, unilateral or bilateral? What was the exact question then? Month of presence with? So because according to me, if this is the question, all four can actually lead to problems of photophobia and watering, right? Acha Harish, unilateral and bilateral cause. So I think I haven't got the exact question here, isn't it? So okay. So what was the question? Was it unilateral or was it bilateral? Congenital glaucomas, of course, commonly they are bilateral but can be unilateral. But generally they are oh, okay. With this alteration in the question, I will again and again, the congenital dacryocystitis commonly unilateral, right? Entropions, I think it is mainly congenital. Entropion is, I'm just loudly thinking with you all only now because suddenly I feel ki, okay, so congenital entropion, tum log batao, that is mainly can be, yes, bilateral, okay. So what was the question, unilateral or bilateral? Yeah. So that is, yes, yes. All seem to be bilateral, except congenital dacryocystitis generally. So whatever is the question, accordingly, we will have to. Okay, we'll come back on this again. We'll come back on this, right? So that this is, you all also remember, and let me just DM me the more exact question, unilateral or bilateral, and I'm going to come back. So we come to the next question here. Patient presents with foreign body or tuna ionoalkali in the eye and complains of irritability and lacrimation. I think this was a simple question, and they are very, very fond of NEET exams. They give question on chemical injuries. Very fond of chemical injuries. Okay, what is the first step? Very simple. First step of any chemical injury has to be a copious irrigation with normal slip. We have again discussed this in the lecture that it is mainly the copious irrigation, even with double inversion of the lid, that should be taken in mind when we are managing any case of chemicals in the eye. That is always the first step. So we will, among all, will first choose this one. Okay? And of course, then you have to remember, apart from starting antibiotics, cycloplegics, we give steroids only for initial 7 days to control inflammation, because then it will start impairing the healing process. So after 7 days, you have to stop steroids. And don't forget about ascorbic acid and citrate, which are given for. Okay? So just revise this for your further exam. Okay? Okay, Harish, agar iPad, but always the first would always be, Harish, your irrigation of eye with normal. That has to be the first step, na? Uske baad hi you are going to pad and bandage the eye. You won't do it before that, correct? So we will answer this only, irrigation of the eye with normal saline. This one is I'm 100. No, 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 no. It's not like that. Don't think in that term, Harish. We have to wash the eyes. We have to try to remove that particle from the eye. Okay. We come to the next question. A 22-year-old patient with high myopia and thick glasses. Immediately high myopia, thick glasses, and presenting with floaters. To my mind jumps to pathological myopia, isn't it? And in pathological myopia, what could be the condition of why will you get floaters? Floaters most commonly has to be, you all remember this? We have learned in the class, that is degeneration, thin, leading to hole formation, leading to rhegmatogenous retinal detachment. And any rhegmatogenous retinal detachment, definitely when there is any retinal break, it is going to cause dispersion of the pigments, and therefore the patient has floaters. Correct? Okay. So, and revise with me, what was that sign known as? We called it Schaffer's sign. The floaters, if there are floaters in RD, it is Schaffer's sign. Or if you remember, we also call it tobacco dust. It's an exam question. You will revise it further for you. For RD, two things. Shifting fluid is exudative RD. Schaffer's sign is rhegmatogenous RD. And yes, before you need PG, please revise your pathological myopia very nicely. Just look at this diagram. Everything is revised in an instant. Nice style, correct? So lattice degeneration, and rhegmatogenous RD. Then another exam question is posterior staphylomas. That's also exam question. Peripapillary annular crescent, tigroid fundus, Foster Fuchs spots. So just revise all this for your further exam. So yes, here our answer is RD. Right? Okay, we come to the next question. All of the functions are superior oblique muscle except, come on, we are back to the basics. We have to be thorough with your action of muscle. What is the action of the muscles? I've taught you how to make it very simple. Horizontal, vertical. Vertical muscles में superior oblique का what is the action? Primary is intorsion. And of course, it's an oblique. It will depress the eye and abduction. So what is the answer here? Adduction. What is not is adduction. So answer will be A. Yes. Right? So here we will answer A. Yeah. Next we talk about, after this, is this question: in an oculomotor palsy, which of the following action is not compromised? So we all remember our LR6, SO4, rest of the muscles supplied by third nerve, right? What are the muscles supplied by third nerve? Superior rectus. Then we have medial rectus, inferior rectus, and inferior oblique, right? So all the actions are hampered, except which are the actions which are not affected? Abduction due to LR, and of course superior oblique action we have just revised with me. All these actions are, so that is the reason in a third nerve palsy we have learned that the eye, so we have learned this, that the eye is down and out, correct? So depressed and abducted. So यहाँ पे आप क्या लिखोगे? Which of the action is not compromised? Of course it has to be abduction. Flexion is the work of lateral rectus. See, these two were so simple questions. You should have been happy. Very, very simple question. Okay, we come to this one. It's a simple question because see, it's a one-liner. Many are one-liners here. So that is why many of you, when you say no, why one, while Q's and double Q's, which I'm teaching in your class, I keep pressing on. Please make a Q. Double Q is your repeated question. Please make a double Q. So why I say so is because of this. Okay. So this will never run away anyway. Especially in ophthalmology, we will have one line. So most common cause of the proptosis in a middle age, there it is unilateral. How do you classify proptosis? Unilateral, bilateral, axial, non-axial, painful, painless. पढ़ा है ना? So whatever it is always thyroid eye disease, right? For adults, and for children, what you have to learn? Taught you this. For children, again, for adults, see, most common cause discussed in the class in adults, either unilateral or bilateral, is always thyroid disease. Whereas for children, unilateral का क्या cause है most common? We answer orbital cellulitis. If you don't remember, please revise it now. Okay, for your further exams, it is orbital cellulitis. And bilateral में, you will answer neuroblastoma. Harish, what are the options then? Thyroid was given as an option or not, Harish? If thyroid was an option, whatever may be the option, our answer has to be thyroid only. Okay? If thyroid was given, we are not worried. Then this is the answer. Okay, Harish? Okay, so when you say or by optic nerve, Harish is saying the other option was optic nerve meningioma. Taught you about what are the, of course, revise this for your further exams. What are the features? It is in a middle-aged female, more common in patients of NF2, not NF1, correct? Then meningiomas, mainly meningoepithelial cells. You have to remember Samoma bodies, right? And what is the appearance? Tubular enlargement of the optic nerve. So all those points you have to keep in mind. But yes, it is not the most common cause of proptosis. Okay? Always most common cause would be thyroid eye disease. And of course, the second you are saying is about soft tissue tumor in the orbital. Okay, you mean to cavernous hemangioma is considered as the most common intraorbital tumor. Okay, hello, let's revise about most common. Let's do that because it's confusing. If it is confusing you all, let's revise it very quickly. Most common intraorbital tumor of adults. What will you answer? Cavernous hemangioma. So am I not talking of benign because I didn't mention malignant, correct? Okay. So when we come to most common intraorbital tumor of children, again we are talking about benign. So here, what will you answer? Earlier we used to answer dermoid cyst, but now we answer capillary hemangioma. So the latest edition of Kansky says it is capillary hemangioma. Okay. When you talk about malignant, most common primary malignant tumors. Okay, you can write it the way I'm writing. Now this for children and adults. Okay, for children and adults. For children, most common intraocular or intraorbital. This is the way if you learn, you will learn it nicely. Again, intraocular, intraorbital. Okay, so intraocular, here you will answer, batao, we all know retinoblastoma. Intraorbital, again you all know very well, we are talking about rhabdomyosarcoma. ठीक है, यहाँ तक ठीक है? Rhabdomyosarcoma. Okay, now we talk about intraocular. We all know for adults, we answer choroidal. Very good, keep answering. Choroidal malignant melanoma. We'll answer choroidal malignant melanoma. Right? And when you say intraorbital, we talk about lymphomas. They asked you next year in the exam which type of lymphoma, non-Hodgkin. Which cell type? B. In intraoculars also, we have to also understand if this is not given, we can say metastatic. Right? So again, if this is not given, then we can say metastatic. So this is what we have just written. Could not see, now you must this. So there's a question on most common from this chapter I'm going to tell you. To revise this for your EPG as well. They have also asked you most common source of metastasis in the orbit. पढ़ा है ना? Most common source of metastasis in the orbit. What will you answer? For females, it is breast. For males, it is lung. Okay? You writing? I'll write it here. Most common source of metastasis in the orbit. So for females, it is your breast, and for males, it is lung. Okay? So this is how you're going to go about these. These are the mainly one-liners in your orbit chapter regarding the causes of proptosis. Yeah, yeah, Pihu, but which UVL you have to mention? Uvea is iris, ciliary body, choroid, all three. But here we have to specify choroidal malignant melanoma. Okay? Okay? So this should be absolutely clear to you all. So, I think these were the questions. Any other questions which, if I haven't received and you want to ask, you can even DM me on my Insta, okay, Telegram. You can of course listen to you and I with. But apart from that, I think there were two questions still into debatable, if I remember. One is when it is you all are saying the increase of pressure is mentioned on the other side, other eye, which doesn't make much sense. But okay, let me see to it what it is, right? And exact question, if you can please tell me about unilateral and bilateral in a small three, so that we can come to the right answer what it is, because it was not mentioned in this question. We are stuck. Okay? So whatever you have to now learn in terms of unilateral and bilateral. Okay? So we will again research on these two questions. What were the exact questions and come to that. But yes, as of now, we are going to know that this is phacolytic glaucoma. Okay? One question on LPS palsy. Okay? LPS palsy, I don't know what the question was. Can you share with me, Shiva? LPS palsy will, okay, very quickly is supplied by which nerve? It is the third nerve. So it is going to lead to ptosis. Yes. Okay, PU, insensitive cornea. So when you say insensitive, there are two situations. Either there is loss of sensation altogether or it is decreased sensation. So cornea supplied sensation kahan se? Think with me. If you think like this logically, fifth nerve. So what can be the causes of decreased sensation in the cornea? I've taught you in your lectures. It is number one, you should always remember viral keratitis. We have learned that the pathognomic feature of a viral keratitis is decreased corneal sensation. What next? Keep writing, keep writing. I'm not writing, but you write. Second, it could be leprosy. It could be diabetes. These are all decreased corneal sensation. Okay? Total no sensation would be mainly in section of the trigeminal nerve. Then you will get no sensation. Okay, apart from that, can we think of some more causes of decreased corneal sensation? Think yourself some more chronic degenerative corneal disorders like absolute glaucoma. That could be later lead to corneal changes and decreased sensation. Isis bulbi, a blind shrunk eye, again sensation not there, very less or not at all. Okay? Acha, yeah. Okay, Harish, what was the question on leprosy and Lyme's? I think, are we talking about, because at the last moment I got this, I haven't included in the slide here because it was very at the late moment. I think there's some question on multiple cranial nerve palsies. So this gives you a message, just revise this, right? So multiple cranial nerve palsy would definitely, we are going to talk about leprosy. So please give me the question, then only I will be able to help you all better. Maybe when we come to the final question, we can discuss it further. Acha, same as in insensitive. Leprosy. I told you, no, decreased corneal sensation. One of the causes leprosy. If both questions are same, then we are not talking about cranial palsy. We must be talking about some other. But I think this is makes sense. Okay. So it's a third nerve palsy ho gaya, it's a fifth nerve palsy because LPS palsy and loss of sensation, fifth nerve palsy. third nerve palsy, and the fifth nerve is also gone, which is the sensory supply. So then multiple nerves are gone, right? Causing paralysis or so Shivam has given me that this is paralysis of the LPS or Muller's muscle. Leg of thalmos is also there. Okay, so seventh is gone. Leg of thalmos is due to what? It is in the facial palsy, isn't it? It is supplied by, it is supplying the orbicularis oculi. So even that is gone. The seventh is gone. And if you say LPS third is gone, eventually leading to blindness. And okay. And these are the options: Lyme's disease, leprosy, ophthalmia neonatorum trachoma. We all know about ophthalmia neonatorum. What are the causes? Chlamydia, gonorrhea. We don't think in that term in this. It is absolutely clear that this is excluded. Trachoma is also excluded. Lyme's disease won't be a better option. So I think it's obvious it has to be leprosy. See the month. So I think I got the right question here. That there's palsy of third is gone, seventh is gone, fifth is also affected. You know? So we should answer leprosy here. This question. That's okay, Harish, but here I think we have to go towards leprosy. As of now, the Shivam has posted the question. Answer should be leprosy. Right. So for regarding the two questions which are still a little bit ups and downs, just DM me the exact question and we'll come back to you. Maybe a quick discussion on that on my Insta or yes, Pihu is saying yes. So yeah. So obviously you, this is the only, I think the options were so easy that you all must not have made a mistake. Options were not difficult. Question. Is it? Right. Any other thing we will discuss? So one more very important thing, because it's always a protocol for me to thank you for these flying hearts. God bless you all. So another very important thing which I want to tell you here is this exam ended is actually beginning of a more bigger and an important game, right? So don't take too much time to come back to your zone, right? Don't get to reboot yourself very quickly. Don't zone out for too long. Take a break. You deserve it. Take a break. That's very important. Recharging yourself is absolutely very important, but that break has to be a very smart one. Short break and start studying again very, very seriously. Okay. Start with your schedule and kick off fast very quickly. Okay. Because we are still not done, right? Yeah. And you have to be fighters. Can't crib, you can't fail, you can't give up. Remember that. Right? Okay? Are you all there? Say yes. Say yes. Promise me you're going to come back quickly and start studying seriously. Yeah? All of you? So that was all about today's discussion. Any other query or shall we stop? Okay. Okay then. Yes, thank you, Pihu. That was such a good yes, and thank you so much for responding. I want all of you are equally precious to me. All of you, I need a yes from you all. Study hard, okay? Yeah. So I'm ending here now. Stay blessed. Keep smiling. Thank you.